Welcome to this explainer. Today, we are stepping right inside the ultimate training ground of clinical psychology. If you've ever wondered exactly how practitioners are taught to navigate the incredibly complex human mind, well, you're in the right place. We're going to strip away the mystery and examine the actual educational blueprint used to build a clinical psychologist from the ground up.
Okay, let's dive into this. Here is our roadmap. We'll be moving systematically through foundations and educational models, ethics and boundaries, the science of diagnosis, treatment controversies, and finally, the future of practice.
Module 1, Foundations and Educational Models, the Path to Practice. So there isn't just one single way to become a clinical psychologist. The field actually relies on three primary training models. First up is the Boulder model, or the scientist-practitioner model, which really tries to perfectly balance scientific research and clinical practice. Then there's the Vail model. This one leans much more heavily into clinical skill development, and it usually leads to a PsyD degree. And finally, we have the clinical scientist model, which heavily prioritizes rigorous scientific research and evidence-supported practices. Each path is going to teach a slightly different balance of research and direct intervention, but let me tell you, they all require some intense dedication. But wait, the learning absolutely doesn't stop at graduation. 10 to 12, that is the estimated half-life in years of a doctoral degree in clinical psychology. I mean, really think about that. Within a single decade, half of what a practitioner was taught might be completely outdated because of new research or emerging tech. This is exactly why continuing professional development, or CPD, isn't just a suggestion. It's an absolute ethical requirement to ensure practitioners stay competent. Moving on to Module 2, Navigating Ethics and Boundaries, the Rules of Engagement. Let's put yourself in the clinician's shoes for a second. You've spent months building trust with a client, and they've shared their deepest, darkest secrets with you. But when must you, as a psychologist, actually break that sacred confidentiality? What are the absolute hard limits of client privacy? While protecting client privacy is obviously a huge obligation, clinicians are taught that protection sometimes absolutely must outweigh privacy. You are legally and ethically obligated to break confidentiality if there's an imminent risk to the client or to someone else, in any cases of suspected child abuse or if you get a formal court subpoena. It is a really heavy burden, having to balance that fundamental trust with actual physical safety. So the crucial point here is boundaries. Let's look at something called multiple relationships. This is when a psychologist takes on a secondary role with a client outside the office. Students are taught from day one that these are strictly prohibited if they risk exploitation or impair the psychologist's objectivity in any way. To be crystal clear here, sexual intimacies with current clients are absolutely forbidden, no exceptions, and actually remain the most frequent cause of disciplinary action in the entire field. Objectivity and safety are just paramount. Module 3, the Science of Diagnosis, Research versus Intuition. For decades, there was a really heavy reliance on subjective clinical intuition. But because human judgment is incredibly prone to heuristics and cognitive biases, trainees today are anchored in evidence-based practice, or EBP. This basically replaces guessing with a rigorous synthesis of the absolute best available research, clinician expertise, and patient preferences. And this brilliantly illustrates how a modern treatment plan actually comes together. A clinician is taught to not just pull a therapy out of thin air. Instead, they first consult the best available statistical research. Then they filter that data through their own clinical expertise to see how it realistically applies to the actual person sitting in front of them. And finally, they integrate the patient's own unique values and preferences. It's a truly collaborative, science-backed triad. Now, in navigating diagnoses, practitioners really have to reconcile differing frameworks. On one side, you have the traditional medical model, which basically views disorders as diseases with symptoms that need to be cured. But on the other side is the biopsychosocial model. This is a much more holistic framework taught today that forces the clinician to examine the really complex interaction of a patient's biology, their psychology, and their social environment. Module 4, Treatment and Modern Controversies. What actually works? Okay, let's go back to 1952. Psychologist Hans Eysenck dropped an absolute bombshell on the field with this quote: "Therapy is no more effective than spontaneous recovery." He essentially argued that people would get better entirely on their own, just with the passage of time, without any professional intervention whatsoever. This provocative challenge literally rocked the psychological world, but it was actually a crucial controversy because it forced the entire field to definitively, scientifically prove its worth. And man, prove its worth? It absolutely did. In 1977, a massive meta-analysis by Smith and Glass countered Eysenck's claim definitively, resulting in this incredible number, 75%. They proved that individuals who receive treatment actually perform better than roughly 75% of untreated people. Therapy works, and the data solidly backs it up. But, modern controversies still rage on today. And perhaps none is fiercer than the prescription privileges debate. Should clinical psychologists be allowed to prescribe medication? Proponents argue passionately that granting these privileges would massively improve access to mental health care for underserved groups, like folks in rural areas or the elderly. However, critics argue just as passionately that adding psychopharmacology training would come at the direct expense of deep psychological expertise, risking the further medicalization of the profession. It's a massive, clashing debate that fundamentally questions the future identity of the psychologist. Another absolutely critical modern focus is cultural competence. Students are taught that traditional therapy can inadvertently act as an instrument of cultural oppression if clinicians impose standard Euro-American values, like strict individualism or high verbal expressiveness, on diverse groups. Because of this, multicultural counseling isn't just a single elective class you take once. It's taught as a lifelong, ongoing process of self-awareness to prevent microaggressions that can severely damage the therapeutic alliance. Module 5. The future of practice, graduation, and beyond. So the modern training ground prepares students for a really high-pressure, rapidly evolving world. They have to master telepsychology and understand the complex data privacy risks of AI and computer-based testing. They also must actively manage their own burnout because psychologists are ethically obligated to maintain their emotional health so they don't accidentally treat patients while impaired. They're challenged to serve woefully underserved rural areas. And finally, they have to navigate the intense commercialization of managed care, where third-party payers often dictate strict session limits and demand high accountability through short-term treatments. Which brings us to a final, really provocative thought for this explainer. As AI and medicalization continue to advance, how will clinical psychology maintain its core ethical duty to alleviate human suffering? The tools are going to change, and the educational models will absolutely evolve, but that ethical mandate remains. It's a dynamic, constantly clashing field, and how it adapts will ultimately impact all of us.